this. Did you know 1 in 5 women has a stroke? Know the signs of stroke. Get help fast. FAST. Good afternoon. Thank you for being with us today and welcome to an American Heart Association, American Stroke Association free digital education experience. Today's very important women's health topic is women and stroke. This free digital education experience is sponsored and brought to you by Capital Health. With great pleasure, we introduce and turn things over to our host, Gina Mamoli, Senior Vice President, Capital Health, and a member of the American Heart Association, South Central New Jersey Regional Board of Directors. Gina?
Well, good afternoon and welcome. 1 in 5, that's pretty chilling. So thank you all for joining us this afternoon. This will be pretty informative. I'm sure we'll all learn some really important information. It's a critical topic, women's health issue, women and stroke. I am Gina Mamoli. I'm the Senior Vice President for Hospital Administration here at Capital Health and a board member for the American Heart Association, the South Central region. Capital Health is proud to be a sponsor and to collaborate year-round with the Heart Association on brain health awareness and stroke education. From now until 2024, which seems to be right around the corner, coming too quickly, women's health and reducing the risk in women will be one of 5 community-focused, high-impact priorities of the American Heart Association. And one of the focus areas will be women and stroke. It's actually my why, for why I'm here. We hope that you will walk away today with new information and knowledge and understanding about stroke to help you prevent a stroke or survive a stroke. Yes, you can survive a stroke. We want you to know that stroke is largely preventable, treatable, and beatable. And you will hear 2 wonderful speakers today. The first is American Heart Association volunteer survivor, ambassador, and stroke survivor, Kathleen Zalewski, who will share her personal story of courage and survival of stroke. And she's also celebrating her birthday. And following Catherine will be Dr. Daniel Landau, who's a neurologist here with me at Capital Health at our regional campus in the Institute of Neuroscience. Dr. Landau's presentation will help all of us, especially women, understand more about stroke and what stroke is, how to reduce our risk for stroke, and the warning signs of stroke, and much more. And following that, we'll have Dr. Landau and Catherine answer questions. You can use the chat box and we'll post comments and questions there. So without further ado, it gives me great pleasure to introduce Catherine Zalewski, who will share her story.
Thank you so much, Gina. So I want everyone to imagine a healthy girl suffering the debilitating effects of a stroke, relearning how to walk, how to talk, put on her clothes by herself. All of the things she once knew how to do with her eyes closed, seemingly lost within her brain. Imagine her finding out that she had a patent foramen ovale or a hole in her heart, which she never knew about, having it repaired only to suffer another stroke. That was me, Catherine V. Zalewski. At 28, I had just given birth to my daughter, Ava, in December and entered into a fitness competition to give me the motivation to get back into shape. It was a welcome outlet for me from the challenging and often sleep-deprived joys of being a new mother. I felt like I was on a roll, eating, living healthier, and retraining my body to do all of the things I once knew how to do. Then, boom, I woke up one night to my daughter crying in her crib, and as any mother would do, I went up the stairs to give her a bottle. However, I was having so much trouble seeing that, but I thought it was just sleep deprivation, just being very tired and all of that. And I somehow found my way to my daughter's room. I gave her the bottle and I put her back in her crib. And I took what I thought was a nap. My husband went to work that day after checking in on my daughter and I. And I later found out that our neighbor had been knocking on our door and ringing the doorbell and trying to get in contact with me, and I didn't hear any of it. I was completely passed out for the time being, and it was almost like I just checked out. So, knowing that something was wrong, my husband came home and took me to the hospital. And doctors eventually determined that I had had a stroke. I went from having the title of being a new mommy to being a stroke patient. What? How is that possible? I mean, my main question was why. I had lived a healthy lifestyle. I ate healthy. I was completely dumbfounded. And I spent months doing physical therapy, occupational therapy, speech therapies. Basically, everything I already knew how to do was a jumbled mess within my brain that I had to somehow sort through. It was only until one of the nurses at JFK Rehabilitation suggested to my husband to have me see a cardiologist at Columbia University. And after discovering that I had a patent frame in a valley, or a hole in my heart, I had a procedure to close the hole. For 5 years, life was pretty great. I mean, my husband and I had just bought a new house, and we were living and with my daughter, and everything was going fantastic. I had gotten, in the time frame, I had gotten my personal training license, and we were living our best lives, to say the least. But fast forward 5 years, and I was pregnant again with no complications whatsoever. And I suffered another stroke 5 years after my son was born. At the time, I was back at the gym training, and this really strange feeling came over me. I had to cut the session short, and I told my manager, and my manager, knowing my signs and symptoms of a stroke, because his grandmother had had a stroke, already knew the acronym FAST, the face drooping, arm weakness, speech therapy, and time to call 911, immediately called 911 right away. And the doctors thought I would have to do my inpatient therapies all over again, but my recovery this time around was completely different due to the clot busting drug TPA, the tissue plasminogen activator. Because I was given this drug within the first 4 hours of getting of my stroke symptoms, it sped up my recovery so fast. And what I spent months relearning how to do and all of that, I only was in the hospital for about a week this time around. TPA made all the difference. I specifically don't like to use the term suffered, because while I did suffer, I don't like to have that negative imagery out there. I mean, now I provide care to elderly seniors and in-home care and assistance to the elderly population. And I love impacting others and trying to do what I can. And maybe this talk is part of that reason why I am here today and why I'm able to I just believe that I'm here for a reason, and I will do whatever it takes to find out my why. And thank you so much to everyone for being here today and for everything you do for all of us.
All right. Thank you, Catherine, very much for sharing your story. That was very powerful. So I'm Dr. Landau. I'm a neurologist at Capitol Health. I'm a stroke neurologist, and I see strokes all the time. I'm going to be relating some information about what strokes are, what puts people at risk for stroke, what puts women at a unique risk for stroke, what are some signs and symptoms to know when someone is having a stroke, what can be done if someone is having a stroke, and then what are some things that can be done to prevent a stroke from happening. So there's a wide range of information that to be covered, but I hope to hit on some key points that you'll all be able to go home with to help either yourself, your friends, your family, anyone who can get this information it'll help in the long run to help prevent strokes in general. So as I said, I will be just talking about a wide variety of topics, but just trying to hit on some of the major points to help address stroke in its relation to women and actually in the entire population as well. So next slide. So basically, to understand really what a stroke is, I think is very essential. The term stroke it's used all the time. A lot of people have heard of a stroke, probably have known someone or met someone who's had a stroke before, but what exactly is a stroke? So there's two broad classes of stroke, if you had to lump them into two major categories. One of them is when you have a blockage of blood flow to a part of the brain, and that's what's called an ischemic stroke. That's the more common type of stroke, and that's what I'll be honing in on today. The lesser common stroke type is when you have active bleeding into the brain, and that's what's called a hemorrhagic stroke. There are some differences in what causes the two of them, but since the ischemic stroke is the one that's more prevalent and there's certain treatments, Catherine mentioned this TPA treatment. That's one of the treatments that you can have with an ischemic stroke. So this is the one that I'm going to be focusing on today. There's also something called a TIA, which by definition is a stroke, but its symptoms get better before anything is permanent. So it's transient ischemic attack. It looks like a stroke, but it doesn't have any of the long-lasting effects of a stroke. This is just a picture that's just showing what the two different strokes look like in a schematic diagram. So ischemic stroke, on the left-hand side of the screen, it's showing a blood vessel that has a clot inside the vessel. That clot prevents blood from getting to where it needs to go. It causes injury to the brain, and that causes the stroke. Whereas the other type of stroke, the hemorrhagic stroke, you have some problem with your artery. In this case, they're showing an aneurysm where you get a burst of blood flow outside the vessel and it leaks into the brain. That causes the stroke. So these are your two broad classes of how strokes can happen. Looking at stroke in general, not just in relation to women, strokes are unfortunately very common. About every 40 seconds, someone is having a stroke. Someone unfortunately dies from a stroke every 4 minutes. It is the number 5 overall cause of death. And it's also the leading cause of disability. There's 795,000 Americans every year who are suffering either from a new stroke or a recurrent stroke. And that translates to unfortunately 137,000 deaths per year. And if you, next slide. And if we look at the numbers in relation to women, about 1 in 5 women has a stroke. Now this 1 in 5 women number, it does skew towards the older ages. So it's typically when you're looking at 50s or higher, but that doesn't mean strokes don't happen in people under age 50. When you're comparing men to women, women do tend to have more strokes than men. In part, that is due to the fact that women's average life expectancy is longer. Women do tend to live longer than men, and stroke risk increases with age. So that's why there is a higher, in part, a higher number of women having strokes than men. Whereas stroke was the number 5 cause of death in just the general population, it's number 4 in women. And then amongst women, Black women also have a higher risk than other women within that subgroup. And there's a variety of reasons of why people have strokes. Some of these reasons are things that can be modified, things that can be changed, that can be either with medications, with lifestyle changes, some combination of the two. The modifiable risk factors are what are key in honing in on, because those can be changed. Now, there are some non-modifiable risk factors that unfortunately there's not really much that can be done. Things that cannot be changed are your age, your biological sex, your race, your ethnicity, any kind of genetic conditions. These are unfortunately all things that cannot be changed. But things that can be changed, which are even, I'd say, the more common causes of strokes are the things that can be changed. Things like high blood pressure, heart disease, diabetes, obesity, smoking, high cholesterol. All of these are, there's a lot of interplay amongst these modifiable risk factors. So oftentimes there's an association with obesity and diabetes, as well as high blood pressure. So all of them, if you can improve one of them, you're often going to improve the other factors. And then smoking in and of itself, separate from the risk factors I was just mentioning, is another big cause of stroke. And now that slide was basically applied to men and women. Now, what's unique to women, and this tends to be strokes that happen to women at a younger age, is pregnancy. So the process of pregnancy puts women at a higher risk of stroke because there's a higher tendency for blood clots to form. Not every woman is at the same risk. It depends on the details of each pregnancy. But there is a condition that can develop in pregnancy called preeclampsia. And that is it's an inflammatory state that involves increases in blood pressure, increases in sugar levels, and you can get something called gestational diabetes, which is when you get basically just a temporary diabetes during pregnancy. So these could be healthy women who don't have any of these risk factors previous to the pregnancy, but during the pregnancy, these symptoms, these risk factors do develop, and that puts people, and it doubles the risk of stroke. And so these are things that are unique to women that can occur. Other things that are unique to women are birth control, the hormones that are being that are in those medications can also cause clotting, which can lead to stroke. Other things that this not necessarily unique to women. I did mention about the hormone level, so hormone replacement therapy. Now, people with migraines, there is a higher tendency of migraines to occur in women than men. And migraines in combination with smoking does put you at a higher risk of stroke. So that's another risk factor. Now, atrial fibrillation, this is a heart condition. It's not really unique to women. It happens to both men and women. It's something that is can develop spontaneously as people age. And atrial fibrillation, if it does occur, is a high risk for stroke because of the clots that can form in the heart. Next slide. So now that we've recognized a lot of risk factors that can contribute to strokes, these are some things that you can do to try to remove those risks and lower your chance of a stroke. So this was under the modifiable risk factor list. So getting your blood pressure under control, getting your cholesterol under control, if you have diabetes, getting your sugars under control. All of these start at your primary doctor's office, getting routine, like yearly checkups, yearly visits, and all of these things are checked. Your blood pressure, your heart rate, your blood work, all of these things are routinely checked at your primary care physician's office. So if any of these things are present, they will be addressed and they will be treated accordingly. Sometimes they can be just managed with diet and exercise. Other times, if that's not sufficient, then medication can be used as appropriately according to what your doctor thinks. And as I mentioned earlier, smoking is a very high risk factor for stroke, as well as other medical conditions. So that's something that can, if someone smokes cigarettes, it can be very difficult to stop. But if successful, it can very successfully reduce your risk of stroke. The last thing is aspirin. While it's an over-the-counter baby aspirin, 81 milligrams, commonly used in the prevention of stroke, it is something that I wouldn't recommend just taking it without consulting your doctor, but that is a commonly used medication to prevent stroke. And these similar steps to reduce your risk, if in particular for women, controlling all of the same risk factors as mentioned in the previous slide. And then if there's anything that puts you at a risk for higher formation of clots. So if pregnancy, there's a higher risk of clot formation, birth control, hormone replacement therapy, all of these things can put you at risk for clot formation. So if just again, regular visits with your doctor, making sure all your medicines are appropriate. These are all things that can be done to help prevent your risk of a stroke. So now, how do you know you're having a stroke, or how do you know your family member is having a stroke? So there's a mnemonic, it was already mentioned earlier, called FAST. There's actually a broader mnemonic, B-FAST. That stands for, the B and the E stand for balance and eyes. The FAST stands for face, arms, speech, and then the T is time. But the symptoms that you might have, or someone might have, for the B for balance, that involves difficulty walking, like a dizziness or vertigo type sensation. Then the E for eyes can be difficulty seeing. Typically, it's out of the one half of your visual field. So either difficulty seeing out of the left side or difficulty seeing out of the right side. That can sometimes be a sign of a stroke. And then the F is the face. So if there's drooping of one side of one's face, and when there's a drooping of one side of your face, that typically goes hand in hand with slurring of your words, just because the muscles are weak, so the words don't come out clearly. A stands for arm, and that's weakness of one arm. And I keep on mentioning one side. Strokes are very commonly affect one side. either the right side or the left side. That asymmetry is a hallmark of stroke. So if it's one side of the face is drooping, one arm is weak, that's a big clue that this could be a stroke. It's not only arm, leg can also be involved, so difficulty walking. And then I know Catherine was mentioning about her speech, that she was having difficulty processing things. So it's not just the words themselves sounding slurred. You can actually have a difficulty finding the words you want to say. So it's called word finding difficulties. That can be a sign of a stroke. So there is a wide variety, but if you remember the mnemonic FAST, or you can extend it out to be fast, that can be an easy way to remember what different signs of a stroke are. This is just, again, reiterating things I was saying. The pictures show the facial droop. If you can see how one side of the face is drooping and the other side does not look like it's drooping. The other picture is showing someone who's dropped a mug, so that's the arm weakness. One other thing, the slides are mentioning headache. So headache is sometimes a sign of a stroke, but very often it's actually, there's no pain at all. So headache is something that can go either way. It does not necessarily have to be present to be a stroke. It's oftentimes there's no pain at all when someone's having a stroke. The type of stroke, the bleeding type of stroke I mentioned earlier, the lesser common type, that can often be accompanied by a headache. But the non-bleeding types of strokes oftentimes do not have headache. Next slide. This is just, again, this B fast mnemonic. It's an extension of the fast mnemonic. The B and the E stand for balance and eyes. The F, face, A, arm, S, speech, and T is time. I want to hone in on time, even though it's not technically a symptom. Time is essential because the treatments that can be done to reverse the stroke are limited in the amount of time you can do. The longer you wait, the less likely we can treat it. The medicine that was mentioned earlier, TPA, can only be given within 4.5 hours. If someone comes into the hospital 10 hours, 12 hours after their symptoms have begun, there may already be too much tissue damage to the brain, and it might be too late to give that medication. Well, that medication, it's not allowed to be given after 4.5 hours because it can actually cause harm after too much time has elapsed. So time is essential. The moment something seems wrong, you call 911. Now, there's a wide variety of blood vessels in the brain. Some are large, some are small, some are medium-sized, some are more vital to certain brain functions, some are less vital. Some lead to major, severe, debilitating strokes. Other lead to more mild, smaller strokes. The ones that can lead to the most disability are what are called large vessel occlusions. LVO is the abbreviation. So large vessel occlusion strokes, because they're affecting your largest vessels, it supplies the most amount of brain and it leads to the most amount of injury. The medicine that was mentioned, TPA, can sometimes help break up a clot in a large vessel, but sometimes that medicine doesn't work. You give it, but unfortunately the clot is still there. Thankfully, starting in around 2015, there's been a revolution in terms of stroke treatment. There's another treatment in addition to TPA, and it is a procedure. It's called a thrombectomy, where a surgeon can physically remove the clot through a catheter. So now there's two treatments for stroke. Not only can we give a medicine to break up a clot, we can physically go in and pull it out. And these debilitating strokes, I've seen miraculous outcomes after pulling that clot out. Someone goes from not being able to speak at all, not being able to move half their body, to being able to speak very clearly and only with very minimal weakness afterwards. So there's some really drastic improvements that can be done with these procedures. This diagram is just a way to try to visualize what is actually happening to the brain when someone's having a stroke. The yolk of the egg is significant. It signifies the very center of the stroke, the core of the stroke. This is the part of the brain that gets damaged first, and then the surrounding white of the egg represents what's called a penumbra. This is the part of the brain that if you don't do anything, it's likely going to become damaged. But if you can do something to break up that clot, this is the part of the brain that can be saved. It's called the penumbra, and then if you can get to the hospital quick enough, we can try to get the clot out and save the penumbra, save the potentially damaged tissue that's not yet damaged. And this is, again, explaining these two different procedures. TPA is the medicine that breaks up the clot. The mechanical thrombectomy is the procedure that physically pulls out the clot. Both of these two procedures actually can be done in conjunction with one another. It's not one or the other. If you're eligible for both of them, you can get both of them. This is, again, just mentioning the same mnemonic, FAST. So we've already gone through it: face, arm, speech, and then time. Next slide. And that wraps up the end. So I hope everyone has learned a little bit about what stroke is, recognizing different risk factors, recognizing the symptoms of a stroke, how women have some unique risk factors for stroke separate from the rest of the population, and that wraps that up.
Wow, thank you. I know that there's already questions out there, but I just want to start with how important this information is. I'm stuck on the 1 in 5, and when I look at the number of people, I'm looking at over 80 people on this call right now. It's every 17 of us will have a stroke. That's pretty remarkable. This is critical information to know. And just by Catherine sharing her story, that's impactful, Catherine. It's really important to tell your story and for others to be aware. It's why I'm sitting here, by witnessing a stroke when I was a kid. So our kids need to know what to be aware of. I wasn't aware of what a stroke was. I just knew something was wrong at the time, and it shaped my life forever. So thank you, Catherine, for sharing your story. What a day to celebrate. And Dr. Landau, that's, listening to you again and again, learning more. The brain is pretty remarkable. What the brain can do and how it can recover is truly amazing. Time is brain. How fortunate are we to have a mobile stroke unit to go out and start doing treatment in the field, right? In a driveway, we could do a CAT scan.
Yeah. So the mobile stroke unit, it's something that, I don't know if everyone's aware of what it is. Not every hospital has one. It's an ambulance that can treat a stroke before the person arrives to the hospital. It has the ability to give the TPA medication that we've already described. It has the ability to do a CAT scan in the field before they arrive. The whole purpose of this, of doing the CAT scan right away, is to make sure there's no active bleeding in the brain. As I mentioned, there's two major strokes: the non-bleeding type stroke and the bleeding type stroke. If someone's having bleeding in the brain, you're no longer eligible for TPA. But if you do the CAT scan and you see that there's no bleeding and it looks like someone's having a stroke and they've only been within 4.5 hours, we call the ER and they order the TPA, and then we give it right then and there without having to wait to come to the hospital.
So yeah, lots more to learn, and treatments are improving. But I know there's already questions in the chat, so use the chat to post your questions, and Peter, you're going to take it from here.
Yes, hi. Thank you, Gina. Thank you very much, Catherine and Dr. Landau. Really, really informative, insightful, and emotional talk. So thank you. We have a bunch of questions. And I'll start first. One from Heidi, and probably a lot are interested. Was this recorded and will it be made available? And the answer to both is yes. So we have recorded this, and probably by tomorrow, we will share a link to the recording with all the attendees. So that's a yes. We have a handful of questions, a couple that were emailed in advance, and a number from the chat box. So I'll read this one first from D, probably for Dr. Landau. Since time is so key, by the time someone gets to the hospital, how long approximately does it take for an ER room or other to diagnose before going on to potential treatment, whether that's TPA or the other procedure?
Well, it depends on whether the person has already been notified by the ambulance as a possible stroke or not. So what we commonly get at Capitol Health, our ambulance will pick someone up, and if there's any suspicion for a stroke, they will actually alert the emergency room immediately before the patient has arrived. Now, this is not the mobile stroke. This is just any routine ambulance. So not the mobile stroke unit. They'll call the hospital and we'll get an alert. We'll already know that we have a suspected stroke on route. The moment the patient arrives into the ER, they're already being seen by the ER doctor. If I'm physically in-house at the time, I'll be down there seeing them too. If I'm not in-house, they'll call me, and sometimes I'll video in. So we get a diagnosis very quickly. We don't have, so we're not always 100% sure whether it's a stroke right away. If we have a high enough suspicion that it's a stroke, that can take minutes to figure out, and we can give the TPA very quickly. We have different measures that we keep track of. We call it door to needle time. It's when someone arrives to the ER with a possible stroke, how long does it take between them setting foot or them getting wheeled into the ER versus from then until the time it takes to get the medicine. And we very frequently, the goal is to get it within 1 hour, less than an hour. We give it oftentimes under that, far under that, 30 minutes. So we can get TPA pretty quickly. There are some limiting factors with TPA. We have to exclude certain things that would not allow us to give it. Anything that causes bleeding would be a potential contraindication. So if someone is already on a blood thinner medicine, we can't give TPA. If someone has some kind of abnormality in their blood work that suggests that their platelets are low, or they have some kind of coagulation problem, then they would not be eligible. If they had a recent surgery, they're not eligible. So we have to go through this checklist first before we give it. But once everything is done, it really ends up not being much time at all.
Okay, great. Thank you. A number of others. This is a question from June. Dr. Landau, you mentioned the irregular heartbeat issue, the atrial something.
Yes.
How would I know, or how would I find out whether I or family members have an irregular heartbeat issue?
It's a very good question, because not everyone knows that they have it. Atrial fibrillation, this is the irregular heart rhythm that can develop. It tends to develop in people in their 60s or higher, and most of the time it's the patient themselves, the person themselves doesn't realize they're in this rhythm. It gets picked up on a routine EKG or routine echocardiogram. So one way to try and search for it would be to have your doctor just get an EKG at your doctor's office. Now, some people, if the AFib is severe, then you might feel it. You might feel your heart racing. You might feel palpitations, like your heart's thumping. You most likely will not feel any chest pain. There's different reasons people get pain, but for AFib, it's either your heart racing, your heart thumping, but you also may not have any symptoms at all. And that does make it a challenge to diagnose someone with atrial fibrillation. Hope that answers a little bit of that question.
That's great, thank you. And I want to clarify the comment I made about the recording. Our production team clarified that we will be sharing this with everyone, but it may be a few days. Our communications team has to look at it, and we have to review the closed captioning. But we will be sharing the recording with everyone on the webinar today, so it will be coming. So this is a question for Catherine. And it is a thank you for sharing your story. Happy birthday. You look and sound great. And they're just curious, since your second stroke, how has your life been since the stroke? Do you continue to live day to day with different aspects of the stroke?
Yes, so thank you for the question. First and foremost, I do have some residual effects. In particular, my memory, I work very, very hard. I try to remember as much as I possibly can. That's why you probably saw me reading some things, some notes that I had jotted down, because I know my story, but everybody else does not. So I would say my memory, number one. Number two, my vision. I do have double vision. When there's a lot of things that are happening, that is when my wires get crossed, basically, and everything goes haywire. And so I have learned that I have to almost hyper focus on one thing and block out everything else so that I can stay focused. So I basically learned how to manage myself and be a real advocate for myself and for my own health, and really try to do what I need to do to stay healthy. So thank you for the question.
That's great, thank you. Here's a question from Valerie, Dr. Landau. This is a clarifying question about the risk or implications about pregnancy. If I had one or more pregnancies, does the increased risk occur only while I am pregnant, or can it continue afterward or any time in my life? Just clarify the time frame of risk relative to pregnancy.
Yeah, that increased risk is only around the time of pregnancy and the very short term afterwards. After delivering the baby, the woman's body basically goes back to its previous state, and that increased risk of clotting is no longer present. So it's only a temporary risk during the pregnancy and then the short weeks afterwards. But then things go back to the same pre-existing risk.
Great, thanks. A few more. This one's from Wendy. Are women who have PVCs more at risk for stroke?
So PVCs could potentially mean that there could be some kind of a underlying arrhythmia, but in and of itself does not put you at a higher risk of stroke. It's something to be aware of, that but oftentimes PVCs don't really lead to any types of problems. So by themselves, they don't put you at risk for stroke.
Okay, great. So there are a few more questions, but we are tight on time and we need to wrap up. We will answer these other questions and share them with the people that asked them. So we will respond to the remaining questions. So I'm going to wrap this section up and turn it over back to Gina for closing thoughts and remarks. So thank you, everyone. Great questions.
Mute button. Really great questions. So much to learn. Thank you so much, Catherine, for sharing your story. It really is truly inspiring, and telling your story over and over again will help others for sure. And Dr. Landau, very educational. You hear from the questions, people want to know more. It really is an important topic to get out there. And thank you to the American Heart Association for hosting this digital event. We've got lots more coming through May, American Stroke Month, National High Blood Pressure Month. FAST, face, arm, speech, time, warning signs of stroke. Remember, it's an emergency. Get out quickly, 911, 911 if you're experiencing any symptoms. Better to be safe than sorry. If you feel anything, if you notice a difference, call for help and teach your family, grandparents, children, what those signs and symptoms are so they'll know to call for help. I think that's all for today. We had over 80, close to 90 people on the digital event today. So get that information out there. And thank you for joining us. We have a video to share.